My name is Mike Carroll, and I'm a licensed massage therapist, strength coach, and neurokinetic therapy practitioner. I own Uplift Licensed Massage Therapy and Wellness right here in Kingston, New York. And I work with people who are in chronic pain or experience chronic repetitive injuries. This has kind of been the little niche specialty that I've found myself working in for a lot of different reasons. But basically, my whole practice is based around people who fit into this category, with people scattered around, of course, on the outskirts of that, but primarily this is the population that I work with and I work well with. In working with this population, there are very common things that I hear when people come into the office, mainly honestly kind of lies that they were told by other practitioners and other medical professionals about their pain. And there's a lot of misinformation around pain in the world right now. And it's not to any fault of anybody. The medical system and the insurance-based system isn't really focused on handling the root of somebody's issues. It's more so focused on throughput and just like managing a fire. It's designed for volume, for understanding generally what can be beneficial for somebody who fits into this category, and giving them a preset protocol that they can follow that hopefully will help them. What I found, especially with people who are in chronic pain, is that you are N of one. You are an individual who has their own history, own beliefs around pain, and own individual movement patterns that you've adopted either to avoid your pain or in something creating the pain that you're experiencing now. Oftentimes, these preset templates don't really work for that individual person who's been experiencing this pain and this repetitive injury for a long period of time. They need something that's more specific to themselves. As a result from all of this, a lot of people walk around with these different beliefs surrounding pain that aren't entirely accurate and might be doing more harm to them than being beneficial. We're going to go through 7 different lies that the medical system has told you about the pain that you're experiencing. Again, I don't think it's necessarily malicious on the practitioners. I think they're just doing the best within the system that they're in and with the information that they have. Lie number 1 is that pain means that something is damaged. There's been a lot of research coming out recently supporting the idea that pain doesn't necessarily mean that damage is going to be present. Let's understand what pain is first. Pain is an output from your brain. We do have receptors that detect nociception that will basically tell the brain that something potentially negative is happening. The brain then interprets that information and then will output pain, because pain is a behavior modulator. It's basically there to tell you to stop doing what you're doing, change something because something isn't going right. Unfortunately, that signal isn't always productive. Your nervous system can be hypersensitive and it can just send that signal, that pain signal outwards, despite nothing actually being really wrong. And this has been proven through a bunch of different studies. You can have significant tissue damage and zero pain. You can have significant pain with zero tissue damage. This has been replicated a bunch of times. This is basically just a fact at this point. I'm sure that we all have intuitively understood this to some degree. You might know somebody who has had a similar diagnosis as you. Either you were in significant breathing pain from it, and the other person wasn't really experiencing that much pain despite the situation being virtually the same. Pain is a very individual experience. There's a lot of factors that go into it. Tissue damage is just one factor of the probably hundreds of factors that go into it. Now, of course, sometimes when there is tissue damage, such as a bone break, you're going to be experiencing pain. The majority of people that are 40 and over who get MRIs of their spine will be diagnosed with some sort of a disc herniation or disc damage and will be completely asymptomatic. The more interesting question that I always like to ask is not what is the damage that somebody's experiencing, why is there damage in this point in particular? And that question can often provide a better benefit in the long run than just being scared of what the actual diagnosis is. Again, the first point is that tissue damage doesn't necessarily mean that you're going to be experiencing pain. This easily gets us into lie number 2, which is your scan shows everything that you need to know about your pain pattern and your injury. Remember, any type of imaging is a snapshot in time. You are looking at somebody typically in like a laying down position, which isn't even specific to working against gravity in an upright position. And going based off of what we just talked about in lie number 1, we know that just because you have this damage, it doesn't necessarily mean that that damage is contributing to the pain that you're currently experiencing. Chances are that damage was probably there for some period of time. It just took a while for you to become symptomatic. Just because, again, you're symptomatic doesn't mean that that thing is necessarily causing the symptoms. There's a myriad of ways that you can chop this up and figure out what are the main contributors towards your pain. It could be that you had this damage, plus a really major stressful life event happened. You didn't get a lot of sleep for the past 2 weeks. Your diet's been kind of crappy. You've been drinking a lot more alcohol. All that is going to add up into being a positive environment for you to create pain as a response. But there is a bunch of other variables there, not just that piece of tissue damage that you're experiencing. If you didn't have all those other variables, there's a high likelihood that you wouldn't be experiencing pain right now. There's a perfect crescendo of all these things happening that then led to you experiencing your pain. Don't get me wrong, imaging is extremely useful, but you can't get yourself attached to everything that's found. Sometimes becoming attached to the diagnosis, you yourself become the diagnosis rather than an individual. You become somebody who fully identifies as this thing. When that happens, the injury or the damage basically overpower you. You can create a fragility mindset on accident because you think that I can't do things because I have this, which isn't entirely true. Of course, there's exceptions based on what the damage is, blah, blah, blah. Overwhelmingly, for most people, it's just information that can be useful. What I was saying before about what I really like about imaging and and learning about what structurally might be happening is, for whatever reason, there's a lot of force going into this region where some sort of a change in the structure is happening. So let's just talk about arthritic changes in joints. Why is it this joint in particular that's taking so much load that we're eroding away the cartilage, that the bones are coming too close together, and they're then responding by laying down more bone and creating arthritic changes? Why is it there, and why isn't it somewhere else? What is happening within this chain of movement and metabolically with this person that is causing this region to respond that way? Again, that's always the question I ask myself. That will inform the type of interventions that you do in terms of creating a long-term solution. Of course, doing some local strengthening stuff and whatever is always beneficial. It may not be the thing that you need to really get to the root of the issue in the long run. Getting to that root is usually some multifactorial thing where you have to account for what's happening up the chain, what's the core stability looking like, what's your diet, what's your sleep, what's your sociological relationships that you have with people. All these things do play into it and are very important. Imaging certainly has its place. It isn't the only thing that you need to consider. Just because you find something in imaging doesn't mean that you need to immediately go into surgery to correct it. That is absolutely not true. Lie number 3 is that everything that's tight needs to be stretched or needs to be released. This one I'm extremely passionate about as a massage therapist, where your training is to learn how to massage tissue, how to do a bunch of different soft tissue releases to decrease tension in somebody. It's extremely well intentioned. I think that massage therapists probably have the best manual therapy skills of all practitioners because it's literally the only thing that most of them do. It's a very incomplete model, especially if you're working with people who have repetitive pain and repetitive injury. The only thing that tightness tells us is that there's a motor control issue or a stability issue, or that basically that your nervous system is in some state where it is applying and it is telling the muscle to keep hold of a lot of tension despite there not being a lot of taxing being put onto it. Basically, the way that I like to conceptualize it is that the nervous system doesn't trust it to be able to control joint positions and to lengthen and shorten in the way that it needs to. So it's just putting a parking brake on it and telling it you're going to stay right where you are because this is more predictable. There's something going on where we're not able to centrate the joint and then create force around that joint centration to allow you to move. So things can become tight in a very lengthened position. For example, if I take this rubber band and I stretch it, this has a lot of tension through it. On the flip side, something can be tight and shortened and contracted. For example, if I go like this, I am shortening my bicep. There's tension through it. If something is shortened and facilitated, that absolutely gives you reason to be able to release it, stretch it, do soft tissue work, whatever it is. If we take that same approach to something that is tight and inhibited or eccentrically loaded and is already holding on for dear life, trying to elicit as much control over the joint as possible, then we might further inhibit it and further lengthen it and further decentrate that joint and make it harder for it to have control. Think of it like this. We have, when you go bowling, you can put the bumpers up. The bumpers help the ball stay in line. Imagine that you were just throwing that bowling ball into one side of the bumpers excessively over time. Eventually, it probably would break. Not to say that doing stretching and massage therapy is going to guarantee that anything is going to break and cause damage. That analogy can work, especially when you start to apply load and movement into somebody who already has a history of this repetitive injury. They've already been stretching stuff. They've already been doing a bunch of soft tissue mobilizations onto things. At some point, there is a more extreme injury that happens. I'm putting it out there that this might be a contributing factor to why certain injuries can happen. This is why blanket advice and blanket deep tissue massages, deep stretching, things like that, I don't enjoy when working with a population of people who are in pain, because it's an incomplete model. You need to do more assessments, such as using neurokinetic therapy. It's a great way to be able to assess this and figure out what things are lengthened and inhibited and what things are shortened and facilitated. Going on to lie number 4, the pain is coming from where it hurts regionally. This is very incomplete as well. There's this concept called regional interdependence, where basically one region can affect another region. That's literally the bare bones of what it means. We all intuitively know this, right? If I get hurt at my hip, then it is going to affect how I load my whole leg. My knee might start to hurt later. My ankle might start to hurt. My back might start to hurt because I'm like moving around in weird ways, trying to work around this pain. So only looking at the specific region that is hurt is a very limited way to work through pain, especially when you consider what region you're working with. For example, your knee pain is very unlikely to actually come from the knee. The knee is a pretty stable joint. It does have a lot of range of motion in one particular plane and some in a rotational plane. The knee is going to respond to what's happening at the hip and what's happening at the ankle, more so what's happening up the chain at the hip. That's probably going to be the thing that's more likely happening. If we're just doing a bunch of knee stuff, whether it be like tibial rotations or like knee isometrics, quad strengthening, calf strength, all that stuff, it all has its place and it's all totally fine. I'm not saying to stop doing that thing. It's incomplete. If the hip is the driver of knee dysfunction, if our hip has an inability to stabilize, inability to go through full range of motion, you are going to search for that range of motion somewhere else. Some people just search for it at the knee. You can see this when people have a valgosity, so their knees touch, they go in, or a varus, where the knees run away. So varus, run away, valgum, go in. Your knee doesn't have any frontal plane movement. It shouldn't bend that way. Like that, we have zero degrees of range of motion in that plane. People end up forming these things, most likely because there's something down the chain, up the chain, whatever it may be, that is causing the need to adapt. Easily conceptual idea to adopt. You add in the fact that we have a nervous system that comes from our spinal cord. I saw this literally this week, actually. I think a few times in the past week. Like somebody's lower extremity issue could be stemming from their back because your lower back houses the neurology of your lower extremity. We have movement subsystems of how we transmit force through the body if one of those subsystems isn't working well. Like you can really extrapolate this out. While starting local and looking at the local area is definitely a very, very smart idea, if you don't kind of expand out in a more global nature, or at least like going to the region adjacent to it, then you're probably losing a lot of potential progress. Going into lie number 5. You failed PT, so nothing will work. I don't like this lie because it's incomplete. All these things you're just going to learn are very incomplete. For one thing, a lot of PT places are very constrained because a lot of them are insurance-based models. Insurance-based models are great because it does provide care for people who may not be otherwise able to afford it. There's also an issue with it. You are a diagnosis code. The insurance company has a preset program or just things that it will allow the practitioner to do. Otherwise, they will not get paid. And you're going to have to front the bill, or more likely, the clinic just isn't going to get paid for the work that it's doing. They have to be able to reason to the insurance companies why they're doing stuff. If you're coming in with knee pain, somebody starts doing lumbar spine work because there's a inkling that you have a core stability issue that is causing your hip to decentrate because you're not able to effectively force transfer into it, then your knee is taking up the brunt of it. That's not going to fly. This 100% is not going to fly unless there is a specific spinal cord injury or there's some radiculopathy that is causing everything down chain. Then I'm sure that they'd be able to reason it. If that isn't clinically significant enough, it's going to be really hard for them to present this to the insurance company. It probably won't get covered. This is not at fault to the therapist. This is just at fault to the system at large. Also add on to the fact that a lot of clinics are not getting reimbursed for as much or as often as they should. The model is just broken. PTs are in a very stressful spot. I feel for them. And it's not an issue of you failing. It's just that the program ended up failing you. Then it becomes focused around getting as many people in as possible so that way you can bill as much as possible. It becomes just a conveyor belt of pushing people out, which is why the PTs are often overworked. They're seeing multiple people at a time, pushing everybody to techs. It's just really unfortunate for everybody involved. Because everybody knows that this exists, the assessment process is probably not complete. They're probably not finding what you need. They're just constrained by the system and doing what they know the system is going to want from them. So even outside of that, I think that saying that you failed something will start to limit how much optimism that you have surrounding the issue that you're dealing with. I think that's also very dangerous for pain, especially as it gets more chronic. You start to believe that you're just somebody who's always going to be in pain no matter what. On top of that, central sensitization, where you're just going to be more sensitive to stimulus and you're going to produce pain as a response. I am always in the camp that there is something that you can do for the pain that you're experiencing. It just might take some effort and time. I will never claim to somebody that I'm capable of completely removing all of their pain at large, guaranteed, or that they'll never experience pain again. That's entirely unrealistic for a lot of people. I do assure them that we're going to learn more about the pain that they're experiencing, that we're probably going to be able to do more things than they originally thought, that we're probably in the process going to decrease the pain that they're experiencing, and learn that there's things that we can do to modulate the pain and modulate our experience in general. That's just how pain works. If you change the inputs, typically the output will change, barring that the input isn't some really sinister disease, disorder, etc. that you're experiencing, which certainly does happen. And for the majority of the people, that isn't the case. Line number 6 is you need to stop doing the things that you love. Again, just incomplete. Now, there might be a time frame that it's a smart idea to modulate, or maybe that it is a smart idea to give it a break a little bit to let tissue healing take place, especially for when an injury is acute. Like when you're within the first day to 48 hours of specifically an injury and also certain pains, it is probably a good idea. Lay off. You're not going to be able to assess the situation. You're going to be so in pain that any information that you get isn't going to be true. Like the pain is just going to blind a lot of things. Let the pain settle down, let the injury heal up a little bit, get into the subacute to chronic inflammation phase, then start looking. At some point, reintegration of movement and reintegration to the things that you love is going to be necessary for a variety of reasons. So that way you don't create fear avoidant behavior surrounding your pain, which is shown to be a large causation of pain itself. If you're fearful of a movement, you believe that every time that you do this movement that you're going to experience pain, it is entirely likely that you're going to produce pain as a response whenever you do that movement. Add on top of that you start to lose tissue tolerance for the movement because you're just avoiding doing it. Your nervous system will also not have a good pattern or strategy for that movement because you just don't do it as often. So you're just going to fall into whatever patterns that you usually do, which might be contributing to the pain already. You might just load in the stuff excessively, then producing a pain response. Evidence has always shown that graded exposure to movement is a really good way to reduce somebody's pain. You're getting stronger. You're telling your nervous system that you could do these things and not experience pain. You're just coordinating movement. You're learning how to organize yourself, how to brace yourself, how to not use one region more than another. You're just like literally training yourself on how to move. Movement isn't your enemy by any means. You just might have to learn how to move better, learn how to distribute load better, drop the volume, drop the intensity, and retrain yourself back up. But typically, avoiding the movement at all costs isn't a complete story, barring, obviously if you break your femur, don't squat. Let your femur heal. There's some obvious situations where you shouldn't be doing stuff. And most people don't fall into that category, at least knowingly. Line number 7, chronic pain is just something that you need to live with. So your nervous system isn't in a fixed state. It can change. Your brain is plastic. Like it has the ability to adapt and change and create new neural connections, basically. If we know that pain is an output, if we put inputs into our nervous system, then we can probably change the output in some way, shape, or form. For some people, that is medication. You're inputting something that is changing hormonally how you respond, that is changing neurotransmitters that you release or binding of certain things. That might modulate your pain experience. That's how pain medication basically works, depending on what the pain medication is. If all the things that we've learned so far in this talk is that damage doesn't necessarily mean pain, that chances are at some point, if there was tissue damage, that tissue is healed, but you're still experiencing pain. The question is why? We might have a learned experience of pain. If we change the inputs from doing the things that we've been talking about so far, then we might be able to change our experience to decrease the amount of pain that we're experiencing. We can decrease our sensitization to stimulus. We can relearn that not everything that we do is dangerous. We can get stronger. We can increase our tissue tolerance. You can metabolically improve your blood markers. A lot of pain can come from people who are just literally unhealthy. If you have an unhealthy system, you're going to be probably more chronically inflamed. That chronic inflammation is going to be, in part, a nociceptive information going up that your brain's going to take in and put that into its calculation of whether or not it creates pain. Of course, some people do have certain types of pain disorders that are kind of tough to manage. Again, what I'm saying is that you're not at this fixed level of 10 out of 10 pain. You could probably do something to bring yourself down to a 6. That's a 40% increase in your pain. I know a lot of people that would be really happy to bring themselves down from that high level, even down to a lower grade level that is just more manageable. That might be the reality of some people, that they may always have something there. If you can improve the quality of life by dropping things down, I think that's really important. That shouldn't be lessened just because it's not going to completely go away. Also, a lot of people might surprise themselves and it might completely go away depending on your situation, your individual history, your health, etc. I never like you're just going to live with this pain forever. It's just always going to be shitty. You're always going to be in an immense amount of pain. I don't like that. I think it's a really negative outlook. There are people who've had such huge traumatic injuries and things happen to them that were able to bring themselves out of it and live a very happy, relatively low pain life. Those were the 7 lies about chronic pain. I hope that this was very helpful for you to at least give you some more optimism surrounding your pain. Pain isn't a death sentence. Whatever diagnosis that you have doesn't define who you are. Again, chances are there's something that you can do to improve your situation and make yourself feel better. It might take some time. I'm not going to say that it's going to be like an immediate fix. It oftentimes isn't, and oftentimes is a long-term process for a lot of people, depending on your situation individually. If you're somebody who is experiencing chronic pain, you are in the Ulster County area or surrounding area, Dutch County, Greene County, whatever, you are looking for somebody to help work with you on your chronic pain, please do reach out. You can book an intro call through our website at www.upliftwellness.org. During that intro call, we'll have a chat, we'll learn more about what you're experiencing, we'll tell you about how we work and see if we're a good fit for each other. From there, you'll come in for an evaluation. My evals are 90 minutes long. We'll do more of an intake for you. We go through a bunch of different movement assessments, orthopedic assessments, etc. Basically, my goal is to see within the lens that I work, which is largely a movement-based lens, what can we do to modulate the pain that you're experiencing? Can we find any movement patterns or dysfunctional movement that might be kind of constantly contributing to your pain? Is there a way that we can teach you how to strength train, teach you how to load yourself, and how to organize your body and move, so that way you start to experience less pain overall? You just become more confident in how to move yourself. Again, I have people that, some people, it's a long haul. It's tough. We're both doing the best that we can to be able to move the needle forward for somebody. Through the process, they're learning so much about themselves. They're learning that they can still do exercise. They can still strengthen themselves. even though they're experiencing some pain or discomfort. Some people, as we go through the process, they notice huge changes pretty quickly. From there on, it's just a fun process of how can we further strengthen you? How can we further teach you how to load yourself while we still dampen that pain significantly? Basically, when I work with you, we work in a phasic structure where we are going to manage your pain, help you move better. We're going to start to rebuild, whatever that means for the individual. Some people, there's a lot more of a psychological component of rebuilding confidence surrounding movement. Also, rebuilding movement patterns, rebuilding strength, rebuilding really anything that we can possibly rebuild for this person. And from there on, it really just turns into more training and strength. We take the concepts that we learned about this person and we start to extrapolate it more into different types of movements, whatever is specific to the person, whatever kind of aligns with their goals as well. And if this is of any interest for you, just book an intro call with us. We'd be really happy to help you if we're the spot for you. Thank you for downloading our guide. Thank you for watching or listening to this. We hope to talk to you soon. Enjoy.